IFARA welcomes our viewers to this series of programs covering the Retrovirus Conference held recently in Boston. We believe this program covering science, policy, and behavioral issues should be interesting to all viewers in the Portland and Vancouver areas, and especially informative to local medical and non-medical providers in the field of HIV and AIDS and hepatitis. Welcome to the program here at the CROI. We're here with DaveThomas from Johns Hopkins. Today we're going to talk almost as though we were like doctor-patient about hepatitis, because I think it's really important for people to realize the nuances and certainly the big differences between the old days and the new day and today. Yeah. So I'm going to let you start out, Dave, and play doctor, and I'll play patient, and we'll go from there.
Okay, well, thanks a lot. This is a really exciting time with hepatitis C, and there's a couple of crucial points that I want to make. First of all, to dispel some of the mythology and some of the impressions that people have from the old days when we used to give people treatments that didn't always work and were toxic and difficult to take. And now to kind of give patients a sense of optimism and to give them a picture of what is the new era of hepatitis C treatment. Usually I start out with first just explaining what hepatitis C is, because there's a lot of misinformation out there. And in its essence, hepatitis C is just a little tiny virus that you can't see with your eye. It lives inside the liver where it grows, but it spills out into the blood, and there's lots of viruses in the blood. And because of that, hepatitis C is principally spread when one person who has hepatitis C's blood gets inside of another person. So that's the ordinary way it's spread. And so that can be, you could imagine if back when we used to do blood transfusions that had a lot of hepatitis C virus in them, and you would put all of that hepatitis C right into someone's body, and the recipient would get hepatitis C infection. Mm-hmm. Even small amounts of hepatitis C, like that you might get, for example, on a needle that's used for injecting drugs, that could also spread hepatitis C. Yeah. Yep. Mm-hmm. Or even microscopic amounts. You can't even see it that could be on paraphernalia used for preparing drugs, or even for the straws that are used for snorting cocaine, for example. All of that can have small amounts of hepatitis C that can get through either the skin or through the normal linings of the mucous membranes and get into the body and cause infection. The issue of spreading it sexually is also important, and it turns out there's a bit of a conundrum there, a little bit of a paradox, in that it seems like when you have two people who are in what we call a discordant partnership, that means one of them has hepatitis C, the other one doesn't. They can go through time together and decades and not spread the hepatitis C one to the other person, even having sexual intercourse multiple times a week. And so there's that, which makes us feel pretty reassured that it's not so easy to spread sexually, especially from a man to a woman or a woman to a man.
It just depends upon the type of sex that they're having.
Well, we think so, because let me finish that story, because on the other hand, there have been real clear instances where men have spread hepatitis C to other men by sex. Mm-hmm. And we don't know if it's because male intercourse can be more traumatic and have more bleeding. And so, as I said, there's a lot of this virus in blood, and so it can be spread from one person to another, or whether there's something else going on that explains it. But the bottom line is that it's infrequent and really rare from heterosexual intercourse, but it is something that you have to be aware of with men having sex with other men, and that's just a paradox that we haven't fully explained, probably something to do with traumatic intercourse. Mm-hmm. Now, equally important is to know that hepatitis C is not easy to spread within a household by other means. And so, for example, normal kinds of relationships, hugging, kissing, nephews, nieces coming over and visiting, and somebody eating with your spoon, those are not ways that hepatitis C is spread, and there should absolutely be no concerns in any regard.
So in other words, the virus, once it leaves the body, the host, it will then be ineffective?
It can actually live for a while on surfaces like a syringe for up to a week. But that only, it turns out, is important if the virus then gets injected into another person, which doesn't usually happen in the normal kind of household kind of contacts. Only when there's injecting or breaks in the skin. So what we say is don't share razors and toothbrushes, because when you do a razor, you might actually have blood from one person that gets nicked and then gets on the other person. But otherwise, to not worry about normal types of household kind of contacts. And that's important to emphasize.
This is good information, because I think a lot of people that are, anyone in the audience should be aware of this information. To not be fearful. I think the fear is usually of the unknown rather than the known.
And some people stop hugging and kissing and stop, and it just creates unnecessary stress in important relationships. And so I emphasize both what can happen and the importance of protecting other people, and then what won't happen, and the importance of going on with life normally. And as I'll mention a lot more in a second, just curing the hepatitis C, so you don't have to worry about this at all anymore, because once we cure it, then you can't pass it to another person. So I mentioned that hepatitis C lives in the liver, and in the liver it can cause, over a long period of time, scarring. Okay, and the scarring is just like if you were injured and you cut your hand and you got a scar where you had the cut. In the liver, you can have, over a long period of time, the formation of scar tissue. And for some people, that scar tissue can accumulate and cause what's called cirrhosis. Okay, so that's when the scar gets...
Which is dysfunctional areas of the liver.
Yeah, the scarring gets so built up that you can't, you can actually go on Google Images and type the word cirrhosis, and you'll see all these pictures of livers, and instead of a nice, smooth, kind of glistening liver, you start to see these little balls of fibrous tissue, almost like golf ball size fibrous tissue, and that, all that scarring starts to make the liver not work very well. The liver's got a lot of reserve, kind of like your gas tank and your car, and it has a lot of reserve. But when eventually it starts to fail, it can eventually start to fail when you get so much scarring. And so it's important, not everyone gets scarring. The scarring occurs more if people or if they're male, if they're more than 50 years of age, if they have HIV co-infection, and if they drink alcohol more than recommended amounts, and even more than, for example, 2 drinks a day for a man or 1 drink a day for a woman. So alcohol is an especially problematic sort of double hit, double whammy for people with hepatitis C, because alcohol in itself can cause cirrhosis. Hepatitis C in itself can cause cirrhosis, but it's one of those things where you take 1 and 1 and get kind of 8. So the 2 together are really problematic. And then add in HIV, which can also be hard on the liver, and you really can get into a tough situation.
Is it hard on the liver because of the treatments people are taking, or because of...
No, it's just those are all independently hits on the liver. And like I said, the liver's got good reserve, but when you start to have HIV, which kind of limits its reserve, you hit it with alcohol, you hit it with hepatitis C, and over time, that can really become a problem. And it does for some people, and then other people are really having almost no scarring or very little bits of scarring, and then of course there's people in between. Now, we used to have to do liver biopsies to figure that out. So we would put big needles into the liver and take a piece of the liver out and take a look at it under the microscope, and we could say, there's a lot of scarring there, or there's not very much scarring there. And that test wasn't really very popular among patients, as you might gather, because you're putting this big liver in the liver, and even though people do it in the most safe way they can, it hurts, and it wasn't a lot of fun. And even then, we just would take a little piece of the liver. So if you saw a lot of scarring, you knew there was scarring there, but sometimes you wondered, well, what's there that I didn't see, because I'm just taking a little piece of it. And so we've come up with other tests that can also be used to figure out who has a lot of scarring and who doesn't. And it turns out you can use blood tests, and you can use ultrasound-like tests, and you can use the liver biopsy, and together we can usually get a pretty good idea, not exactly how much scarring there is, but whether or not somebody has cirrhosis or not. And that turns out to be the most important kind of issue right now. So we usually talk about how hepatitis C is spread and how it's not spread. We talk about how we find out whether or not it's harmed your liver or not, and whether you have cirrhosis or not. And then sort of the last step in the initial evaluation is to talk about treatment, which is kind of the fun thing now. It used to be the hard thing. I used to actually make people come back for a whole new session to talk about treatment because it was such a difficult and long process.
Before you talk about the treatment,
sure,
there is reinfection.
Okay.
So I'm wanting to say that up front. You
Absolutely.
can be reinfected, so pay attention to the treatment.
Right.
As good as it is today, it's still treatment. So.
That's exactly right. And to me, that's we're in my sort of logical outline, that's at the end when we talk about after treatment, we talk about what can happen afterwards and what the risks are. So let's talk just for a second about treatment. First of all, no more interferon. It's very rare that we have to use interferon anymore. There's some really highly select instances where somebody has a very particular strain of hepatitis C that's become resistant with prior treatment and that sort of thing. But for all intents and purposes, we're talking pills. We're talking pills that you take for no more than 24 weeks, and oftentimes for just 12 weeks. And we're talking about pills that you take for which in studies where people were given placebo initially versus the pills, you really couldn't tell the difference oftentimes between the people on the placebo and the pills. Oh. And just to be clear, in those studies, the people that got the placebos would eventually switch to the medicine, and the people with the medicine would eventually switch to the placebo, so you could sort of make sure that everyone got treated. It wasn't like they were doing not giving people hepatitis C treatment. So we're talking about pills. We're talking about pills that will give you more than a 90% chance of being cured. We're talking about pills that you probably only have to take for about 12 weeks, and we're talking about pills that really you're not going to have many serious side effects. In fact, you might not even know you're on treatment. So that's all the good news. The bad news is the medicines cost a lot of money right now. So sometimes it's hard for me to actually even tell a patient when I first see them which medicine they're going to get. I don't even use the name sometimes because I don't know for sure, unless I'm very familiar with their insurance company, which one is going to be the preferred treatment for a particular insurance company. Sometimes they've cut deals with the manufacturers, and they have special prices for certain treatments and not others. So you sometimes don't find that out until after you write the prescription. So I say I'm going to recommend treatment for a patient. There's almost no instance in which I wouldn't treat a patient. I believe that everyone's better off without hepatitis C than they would be with hepatitis C.
Which was much different the case.
Much different.
So dispel your previous information completely.
You see, in the old days when we had to give interferon, like let's say I had to give you interferon and some medicines that would be very toxic, I had to decide for you, are the benefits of that worth the risks? Because there were definite risks. And so I had to figure out whether your liver disease stage and all the other things about your health made the risks lower than the benefits. And then if I thought that, I would give you treatment. But nowadays, as I just mentioned, the risks are almost negligible, except for financial. And so we don't really try to weigh risks and benefits as much. Most physicians believe that unless you have some advanced form of cancer and are expecting to die in the next year, that we would think you'd be better off without hepatitis C and would recommend treatment for you.
Now, let me just interject here. How many doctors are there that are familiar with, I mean, how familiar are all doctors with this? Because, or do you have to go to a hepatologist, or do they refer to hepatologists?
Well, this is a new area of medicine. It's a rapidly changing area of medicine, and so there are certainly physicians that aren't yet comfortable with doing hepatitis C treatment, and so it's important to go to someone who's experienced, who feels very comfortable with the assessments and the treatments. Because even though I'm making it sound really simple, there are some important issues like being able to understand the test for cirrhosis and interpret them correctly and prescribe the right medicine that still are relevant. But it's vastly simpler than it used to be. I can say that, and there's increasing numbers of physicians that are capable of doing Hep C care. So that's it. We talk. We figure out which treatment's right for you. Write the prescription. You would come back. At that point, we would have what's called a start visit, where we would then have known what medicine was right for you, which one your insurance company approved. You'd have the bottles, and we'd talk about the importance of taking them, being really careful with taking all the medicines. I'd emphasize that these are really expensive, and you don't want to goof it up. You don't want to leave your bottle behind while you go on vacation for a week or something like that. That this is something you really have to focus on for just a period of life, and then get it over with. So then treatment begins. We monitor to make sure that the medicines are working and that there's no issues arising. And then you come back for a visit, usually about 12 weeks after you stop taking the medicine. And that's the one where I usually get hugged. I love that visit because I get to tell people you're cured and your hepatitis C is gone. We use the word cure because if your hepatitis C is gone at that visit, 12 weeks after stopping your medicine, only about 1% of people will ever have virus again in their body that we can detect. And in some of those instances, and perhaps even the majority, that we think that virus was acquired by going out and getting hepatitis C again. And so I say that to emphasize two different sides of this issue. One is when you're cured, your virus is gone, and that's fantastic, and we don't think it's ever going to come back. But the other side of it is that you can be reinfected, as you said earlier. And so I emphasize to patients the importance of not being exposed to hepatitis C anymore, and of being really careful and avoiding any kind of hepatitis C high-risk exposures, and talking about the kind of how to do that in terms of what
the sexual risks are important to understand, I think.
The sexual and the drug use risks, actually, and to make sure that that people understand that you can go out and get it again, and even from the same person that you acquired it from the first time. And so it's fantastic to actually treat both people in a partnership, for example, so that neither of them has to worry again about giving the infection to each other. And so that's important to emphasize. The other part that I like to talk to patients about is, we call it a cure also because the risks of all of the things that I talked about earlier, that cirrhosis happening, liver failing, getting liver cancer, the risks of those events go way down after you get cured, after the virus is gone.
The scarring doesn't go away.
But that's very exactly. But the scarring doesn't go away. So that's kind of why it's so important ahead of time to figure out if your hepatitis C is treated before the scarring gets very bad, you'll never get those problems. And your risks of those problems occurring really go essentially down as if you'd never had hepatitis C, which is really good. So that's sort of cure and don't worry anymore, and I don't ever need to see you anymore unless you want to come and say hi and send me Christmas cards. That's one group of patients. The other group of patients is the ones that had a lot of scarring, either cirrhosis or close to cirrhosis, before they got cured. And for that group, it's a little bit of a different message, and sometimes it's confusing because I say to them, you're cured, You're not going to have this virus in you, and you just reduce your risk of having your liver fail or getting liver cancer by like 80 or 90%, which is fantastic. But notice I didn't say 100%. And so I'm going to have to keep monitoring those patients every 6 months to make sure that their livers don't develop cancer or don't have complications.
Because the scarring is kind of an abuse to the liver.
Because the scarring's already there, and it's a great place for liver cancers to hide out and to form. And so we still have to, just like you have to do pap smears or mammograms to detect cancer early, we like to do ultrasounds in those kinds of individuals to detect cancer early while we can still treat it if they were to develop it. So it's great, you've lowered your risk by a lot, 80 to 90%, but you still have enough risk that I'm going to monitor you and in the years after cure to make sure that you don't develop a serious complication.
And what do you find with the way, because these drugs are very expensive, so I'm sure the insurance companies don't like to pay for a second or a third treatment. What's happening with that? Are there
that's really important, and there's variability. Some insurance companies are, of course, more generous than others, and some state Medicaid programs are more generous than others. And I'll say to you, there are some, especially some state Medicaid programs, that are now not approving treatment until someone gets into that cirrhosis or near cirrhosis state.
Really? No.
Yeah, they're not giving treatment to the person whose liver is really good. So you come in and I have sort of a mixed message on the second visit where I say, oh, the good news is all your liver tests look quite good. The bad news is your insurance company is rejecting the prescription. And
it seems almost bad medicine because, first of all, and it's also a bad community issue because you're now allowing that person to be able to spread.
Yes, it's exactly right. Spread it, and why wait until you get cirrhosis and have all these other problems I was talking about before you treat? It's definitely not good medicine. It's an economic reality. The medicines are very expensive, and some states last year paid 5% of their entire budget for their entire health budget of Medicaid was for Hep C drugs.
Wow.
So that's not giving them to everyone. That's with restrictions. So I'm not saying that I have all the answers, but when as a doctor, I know that a patient is better off not having hepatitis C than having it. So we'll always do our best to appeal and to, if not, to try to work with the patient assistance programs that some of the pharmaceutical companies have to try to find a way to get treatment.
And I also wonder if they haven't run the numbers that, okay, so it is expensive, but if we can bite the bullet and just pay for a massive number of people to be cured, we won't have as many new infections.
That's absolutely right. And in principle, that's right, that if you could all of a sudden treat everyone, it would be eradicated from the earth, period. It doesn't hide out anywhere. If you treated everyone in the next 6 months, it would be gone. And we'd never have it be like smallpox, never again. But the situation is that would cost almost $500 billion. And so even though that would be less than the cumulative costs of treating people spread out over the next 20 years and
it's not in the budget.
It's not in anybody's budget. It'd be like me saying to you, if you spent a couple $100,000 on your house today, you would spend less over the next 30 years. You'd be like, yeah, that's nice. That's very interesting, but I don't.
Here's the time for negotiation. We ought to say to the company, okay, give us all the drug this is what we're going to give you for the cure for the whole world.
Well, there's conversations like that occurring, and there's some very creative programs like in New York where they're talking about even a bond where it's the kind of thing where you would, as with a bond, borrow against a future cost reduction in order to pay for today. So we need to find mechanisms like that and reductions in price. Let's face it, that would help a lot. So those are the kinds of things that we're facing. In the meantime, for a given patient, I think, and a given physician, it's really become, these social complexities notwithstanding, become pretty simple. You want to find out if you have hepatitis C by getting tested. If you have it, you want to go see somebody that knows how to treat it, and you want to get rid of it.
And fight for getting to treat it.
And fight, and because patients that fight and doctors that fight, it usually works out. And you want to get rid of it and then not get it again. Mm-hmm. It's not going to cure all of your problems in life. Mm-hmm. People ask me sometimes, well, am I going to feel all better again? And is all my aches and pains going to go away? And how much of my depression or my fatigue is from hepatitis C? And my only answer is, let's cure it and we'll find out.
Right.
And usually people feel better by a measurable amount, but not everything goes away. It's not it doesn't get rid of 40 years of aging, but it does get rid of a virus that is doing no one any good.
You've covered this very, very completely. I appreciate that you did exactly what we hoped you'd do.
Good.
And we have the doctor-patient program right here. You don't even have to go to your doctor. This is kind of like a precursor of what you're using.
Well, so I can't write prescriptions for everyone today. So.
Be wonderful. Thank you, Dave.
Yeah.
All right.